I am Dr. Sanjay Dudhat. I am Head of Surgical Oncology at Nanavati Super Speciality Hospital. I have been trained in Surgical Oncology at Tata Memorial Hospital. I was there for 7 years, and after that, since 2000, I am working as a surgical oncologist as well as head of the department in Nanavati Super Speciality Hospital till today. Now look at the development in cancer surgery in so many years. Look at the scenario exactly 40 years back. It was a concept of only radical surgeries. Remove the organ as radical as possible, because the concept that cancer was only loco and loco-regional. Now, since the studies came, research came, then the people found cancer is not only loco-regional, but it is systemic. Then, is there any point in taking out the organ radically and giving rise to deficit to the person, deficit of an organ and his well-being? Now, is it correct? Then they studied, say for example, breast cancer. If you have got a small tumor, is it necessary to do a radical mastectomy? And then the concept of organ preservation, that is breast preservation, was evolved. Now the same trials are being applied, and that is why organ preservation and its function came into action in a big way, because it not only preserves the function, but it maintains the uprightness of a human being in the society. Removing of the breast for a female, it is extremely traumatic, but preservation of the breast, she will remain upright in the society and she will be able to perform her activities in a better way rather than a mastectomized patient. This is the concept. Now, when this concept was evolved, initially there were hiccups, but people thought, no, we are getting better and better quality of life, and that's why young people and the concerned people are heading towards organ preservation, and they demand, and that is why this concept has been really popularized. But only thing what we have to do as an oncologist, we have to select the case in a proper way. If you don't select the case properly, then the results will not be correct. Now you have to make the balance, a cancer as a disease point of view and a function. Now you have to balance in such a way that at the same time your oncological safety has to be maintained and the function of the organ also has to be maintained properly, and this equilibrium if you maintain, then the organ function and preservation will be highly successful. When this concept was evolved, we had different organs, we had challenges whether we can preserve these organs or not. Now considering it started with concept in breast cancer. Now breast cancer, in a small tumors, we do give an option of breast preservation, and after that we have to give radiation therapy. Suppose in young patients, nowadays we are seeing a lot of young patients also in India, in our country. So even if the large tumors are there, if we give chemotherapy to downstage and make them amenable for breast conservation, and then give radiation therapy and chemotherapy, whatever is remaining. Now this is how the breast conservation has been done. There were other organs we had a challenge, especially cancer of the rectum. Now this cancer of the rectum, we had a really challenge 20 years back. We used to do complete removal of the rectum right from abdomen to down in the perineum area, and patient has to be on permanently on the colostomy on the abdomen. Now nobody likes colostomy, but that is why the concept evolved of sphincter preservation surgery. That means you are removing the rectum but preserving the sphincter. Now this was possible with the advancement of transanal staplers. These are the machines which you can put it through the anus up and join the rectum to the anus as low as possible. Without these staplers, of course, it is very difficult to do it, but with the staplers, it has become so easy nowadays. So majority people, we are preserving the rectum as much as possible. The same concept of breast cancer is applied in cancer rectum. If there are large tumors, we are downstaging with the radiation therapy, make it amenable for anti-resection or sphincter preservation surgery. Look at no colostomy, patients are so happy, they are going to the office regularly after this operation. This was the challenge in cancer rectum. Coming to cancer of the voice box. Previously, the whole voice box we used to remove. No, but the concept changed. We are giving radiation and chemotherapy combination to the cancer of the voice, to the voice box, so that voice preservation, I think it's the utmost important for any one of us. And that is how the concept came of chemo radiation protocol all over the world for cancer of the voice box, the cancer of the larynx. And that is how we are using this protocol first. Unless this protocol fails, then only we go for a salvage surgery. Same thing was applied for cancer of the alveolus. Whenever there is a cancer of the buccal mucosa, when it is adherent to the mandible, the lower jaw, then we don't remove the whole jaw unless it is involved with the findings of the CT scan. If it is not involved, and if it is just touching the cancer, we are just removing the part of the mandible, what is called as marginal mandibulectomy. Preserving a lower jaw or mandible, it gives a great cosmetics, no question, plus the function of the jaw is well maintained. You can put the dentures after the surgery is over after 6 months. I think that is much better. Same thing was applied to the thyroid cancer, preserving one lobe if the thyroid cancer is small in a well differentiated cancer. Same thing was applied in the cancer of the lung in the small tumors, and even kidney tumors also. We used to remove the whole kidney for 2 centimeter tumor, but we are preserving the kidney by doing a partial nephrectomy. So these are a lot of challenges in all our other organs we tried, and there is a lot of success with a good selection of cases. Always remember, there are so many cancer treatments which are available nowadays, no question about it. But what is the aim in cancer treatment? Cure, of course, yes, cure should be your first choice, no question, but quality of life. In oncology, quality of life is number one agenda. If any treatment or anything you are giving to the patient hampering the quality of life, then treatment is not up to the mark. Then whatever you are going to advise, that should give a better and better quality of life in the patient. See the breast conservation patient, see the sphincter preserving patients. These are given quality of life. Look at voice box preservation patients. This is called as quality of life. A person is a teacher, has a voice box cancer, and is going to take lectures again. This is called as quality of life. And this is how the cancer treatment is based on. The basic is maintaining the quality of life. If you don't maintain the quality of life, then everything becomes improper. I would prefer treatment is successful, but when treatment is really successful, when patient will have an excellent quality of life after your treatment.